Hello friends. I'll be giving a overview on this very perceived simple topic called hypoglycemia in critical care setting, which I believe is a neglected phenomenon. I'll just give you a context as to why we need to speak. So I'm sure most of my intensive care friends who would be listening to this, they would think hypoglycemia is a simple thing. You just give dextrose, things are okay. It's not as simple as that. So I'll give you a clinical context that just happened maybe 2 weeks back. So a patient, elderly lady around 65-year-old with the diabetes, hypertension, on insulin. So she undergoes DJ stenting with acute kidney injury. She has an acute kidney injury. She undergoes DJ stenting, comes to the recovery, and in recovery, she has an episode of hypoglycemia. And the anesthesiologist gives dextrose, and she has a borderline blood pressure also, and then takes a call that she's perfectly fine and shifts to the ward. This is the clinical context. So the question to all my intensive care friends is, in hypoglycemia, taking such a decision, in my parlance, I would call it as a malpractice. Sending a patient who has an AKI, 65-year-old, having undergone DJ stenting, has an episode in recovery, episode of hypoglycemia with a borderline blood pressure, administers dextrose, sends to the ward, and patient promptly comes to ICU with a near arrest. So this is a malpractice to me. If someone sends to a ward after an episode of hypoglycemia post-procedure, I think this is what we need to address in this talk as to why it is terribly important about knowing about the nuances and nitty-gritties of hypotension. So hypoglycemia, sorry. So this is what I wanted to embark upon, because I'm sure most intensivists wouldn't read a chapter on hypoglycemia. And as a physician, it is important we understand. So the topics I cover is understand what is definition of hypoglycemia and what is its prevalence in ICU. So this whole topic is only in ICU setting. What is its prevalence in ICU? This is important for us to know. And what is the outcome? If someone has hypoglycemia, does it have a bearing on mortality? The answer is a yes, big yes. It has a bearing on mortality. It worsens the outcome. So please understand that you can't shift a patient to the ward, or even in emergency for that matter. Someone comes to hypoglycemia, don't give dextrose and shift them to ward. Patient may die there in the ward. That is the message I want to convey in this. Then what are the risk factors for hypoglycemia? And of course, all of us have counter-regulatory mechanisms. That's why age becomes important. Someone elderly, one needs to understand the concept of counter-regulatory mechanisms which are impaired in an elderly patients, and it narrows down. So that the time between the counter-regulatory mechanisms and the symptomology very much narrows in elderly patients, and they do not give much time for interventions to happen, and they end up in a catastrophic situation. So clinical features, I think this we don't need to dwell too much. It's fairly intuitive what happens in hypoglycemia. So maybe in this video, I will not go into the management because it becomes a very long. So I'll just limit until clinical features and conclusions. Management, maybe I'll do as a snippet in the next video. So these are the topics that I intend to cover. So when you talk about definition of hypoglycemia, it is the clinical manifestations with a low sugar. So patients present with symptoms of obtundation or some neurological, it can be confusion, and they do manifest with autonomic dysfunction. So this is the combination of symptomology that happens in the setting of biochemically proven or biochemically established low sugar. So what is a low sugar means or hypoglycemia? As per the American Diabetic Association, blood sugar levels less than or equal to 70 milligrams per deciliter, we call it as hypoglycemia. If you look at Canadian Diabetes Association, it puts it as less than 72. And European Medical Association puts it at much lesser, less than 54. I'll talk about studies. What studies have looked at as hypoglycemia, and when we call it as clinically significant hypoglycemia is what we need to see. So basically, it is the symptomology in the setting of biochemical low sugars manifesting with neurological symptoms or autonomic dysfunction. We call it as hypoglycemia. So that's the definition. And when you look at the prevalence, overall prevalence in the diabetic patients who are on insulin, the prevalence is 3 to 29% is the prevalence. And it is shown that diabetic patients who get hospitalized, 1 in 4 patients do develop some episode of hypoglycemia. See, not all hypoglycemias are bad. Some hypoglycemias may be very subtle. you find out and you correct and you consume some sort of a sugar solutions of some sweet, things would get better at medical correction. But there are varying degrees of hypoglycemia that sets in, and that is where we need to exercise caution. And 20% of diabetics who get admitted into hospital may manifest with some symptomology of hypoglycemia during their course of stay in the hospital is what has been referenced. And 7% of them manifest with altered mental status in the setting of hypoglycemia. So it's a 7% is where things become more sinister and they manifest with altered sensorium, confusion, coma, seizures. So that's where things become very murky and it has a lot more bearing on outcome. So this is the sort of epidemiological numbers or data that we have. And when you look into the ICU data, so this comes from this particular paper from the US, hypoglycemia in patients receiving point of care glucose. So if you see, this is the stratification based on glucose. If you look at less than 70 in ICU, it's around 6.3%. And less than 60 is around 3.7, so on and so forth. So less than 40 is 1 point. So as you see, by then, by 60, 70 to 60, things get recognized, you would rectify, so they don't go into less than 40. But our patient, this particular patient, which I gave you a clinical context, which happened 2 weeks back, went to the ward, came with a blood sugar level of 32 to ICU, with a near arrest sort of a situation, with the confusion and coma. So it's not uncommon. So 1.1% come with that severe situation. This is the epidemiological data. And this is the non-ICU data. It's around 5.7. So you can put the hypoglycemia prevalence in ICU, you can put it around 5 to 6% as a number for all our trainees to keep in mind. So that is the sort of epidemiological data that we have. So this is another sort of a big retrospective study where they looked at patients with severe hypoglycemia less than 40 as a 7-year study. So this came from the US. As you see, they had 102 patients who came with hypoglycemia less than 40, and they compared with the control group 306. And if you look at the mortality, it was 55.9. So which means the mortality in patients who come with severe hypoglycemia is very high. So it's more than 50%. And that was statistically significant. And there were certain independent predictors of mortality in ICU, especially if they are mechanically ventilated or if they have a higher Apache score. So they are at a higher risk of mortality was what found in this particular study. So that's about I'll show you a lot of other data. So this is one data that you have. And here they looked at what are the risk factors for mortality. And this is very interesting. This is important for intensivists to know. Someone who has a AKI bar CKD, the risk of mortality goes up. So just focus on things that are there in the red. Someone who is on mechanical ventilator, mortality goes up. And someone where, what is TGC? TGC is the tight glucose control, where you are trying to attain tight glucose control, mortality goes up. Someone with a higher Apache, mortality goes up. And age, elderly people, the more elderly you get, higher is the mortality. So this patient had all this. That's why I said it's a malpractice to send someone, elderly lady, more than 65-year-old, with the AKI, creatinine of around 2.5 or 2.8 she had, and who's had some sort of a sepsis, undergoes digestion thing, and you send them to ward, what else you would expect? So it does have a bearing on mortality. So please remember, you cannot look at hypoglycemia as a very simple sort of a clinical phenomena. It has a bearing on mortality, and these are the variables which have a bearing on mortality. So what are the risk factors for hypoglycemia? Most important is impaired awareness. This patient had. Someone come from post-operatively, recovering from anesthesia, put them in recovery, has one episode of hypoglycemia. So awareness anyway tends to go down with the elderly age group. And someone who is recovering from anesthesia, who has an infection, has a hypoglycemia, you send them to ward. How sinister can it get? So impaired awareness is a common thing. And someone who's kept NPO, obviously she's come from theater. She would be kept NPO. Increased age, severity of illness, and certain errors. Or someone who has an end organ function. So someone having liver dysfunction, or an underlying diabetes, or someone who has an acute kidney injury. All these are the risk factors for pushing someone into hypoglycemia, or someone with a malabsorption or who is kept NPO, so on and so forth. So this is just a pictorial representation of certain intuitive risk factors for someone at a risk for hypoglycemia. And there are drugs. This is very important for intensivists. So just around 1 week back, I was just having a candid conversation. So there was a patient in the ward who underwent hypoglycemia. And this patient was on dual antibiotics, which again I feel is a malpractice. And I told them, please stop levofloxacin because quinolones are the drugs which push someone into hypoglycemia. So it is important for intensivists to know what are the drugs that push patients to hypoglycemia. So AC inhibitors are ones. Beta blockers. Many of our patients will be on beta blockers. Quinine and quinolones. Just I put as a alphabet. So quinine, quinolones, trimethoprim, salicylates, and sulfonamide. So these are the drugs which we all have to be aware, which can sort of mask hypoglycemia or can act as a triggers for hypo. So quinolones especially, because especially in the wards, physicians tend to use quinolones, AC inhibitors, trimethoprim. They're all at a risk. I mean, I won't say they push someone into hypoglycemia, but they all add their little bit to push someone into hypoglycemia. So that's about the risk factors. So we'll talk about the types of hypoglycemia in critical care. So you can broadly divide them into spontaneous that tends to happen. Spontaneous happens in this sort of a clinical conundrum where patient is on organ supports, is on mechanical ventilator, patient is very sick with whatever reason. They tend to develop, I mean, the severe septic shock, they can have hypoglycemia. Or very often it can be iatrogenic, where patient is on certain medications and there is some interactions with different medications or underlying organ dysfunction which pushes them into hypoglycemia. So these are broadly divided into spontaneous and iatrogenic. And this is important. All of us, anyone who develops hypoglycemia, body has a very beautiful innate mechanisms to combat hypoglycemia. What does body do? So your posterior pituitary releases growth hormone and your pancreas releases glucagon to counter this. And because the growth hormone and CRH, corticotropin release hormone is released from the posterior pituitary, they tend to stimulate your adrenal gland to produce epinephrine, norepinephrine, and cortisol. They all act as counter-regulatory mechanisms to increase your sugar level and try to circumvent that crisis. And we see this sort of a phenomena tends to happen a little bit in the early morning state, or so, especially someone is put into stress. That's why sugar levels goes up in the sometimes in the diurnal variation of high sugars that happen and at the stress level. But in type 1 diabetes, so the reference is that the CRH release from posterior pituitary is sort of tempered down. So that is something that happens in type 1. But these are the general counter-regulatory hormones that tends to happen to mitigate a hypoglycemia event that tends to happen. Okay, so when I say hypoglycemia associated autonomic dysfunction, when I say autonomic dysfunction, where these counter-regulatory mechanisms which I showed you are sort of tempered down and those hormones, cortisol, epinephrine, CRH, they don't get released and patient is pushed into the hypoglycemic event that tends to happen. So when there is increased insulin, so for some reason there may not be increase in the glucagon release that happens from pancreas. Then there is antecedent hypoglycemia because there is no increased glucagon and there is no CRH release, and even there is a tempering down of your adrenal response that leads to decreased sympathetic neural response and reduced in the epinephrine, norepinephrine, or cortisol release. So that leads to hypoglycemia awareness and glucose counter regulation does not happen, and that leads to recurrent hypoglycemia. So this is what happens. So this particular patient who came from the surgery, recovering from anesthesia, elderly lady with AKI, with the autonomic dysfunction, they go into recurrent hypoglycemia because of counter-regulatory mechanisms which are not active. This is what happens. That's why you need to be very vigilant. Hypoglycemia is something you correct with dextrose. You don't send them out of a monitored environment. You need to put them into a monitored situation and monitor the sugars diligently and correct something on the background. And this patient was sent to the ward with 10% dextrose. That did not fix the problem. So this patient, even when they came to ICU, we were giving 50% dextrose. Even with that, we had to monitor every hour to ensure that she doesn't go. She was trying to dipping down with the sugars. So this is very important for us to understand how counter-regulatory mechanisms are terribly impaired in elderly patients. The clinical features, I'll show you another cartoons. So I'm sure most of you know they have sweating, they have some dizziness, headaches, anxiety, irritability, and most importantly, I think what is of relevance to us is they'll have tachycardia, it's a cardiac response. So we'll talk about the very devastating effects hypoglycemia have on the heart. So this tachycardia can lead to myocardial events, which we'll talk about. And neuroglycopenic symptoms is confusion, disorientation, seizures, loss of consciousness. So this is fairly intuitive. So these are something that happens in hypoglycemia. Okay, now we'll talk about what is a normal physiological response to hypoglycemia. This is very interesting for all our trainees. So this is just the scale of the sugars, 70, 55, 35, and 20. And at around 55 to 70 is where counter-regulatory mechanisms get kicked in, where you release glucagon, you release epinephrine, norepinephrine, cortisol. So this is where the auto setting or correction should happen. At 55 to 35, they'll slip into complete awareness. There can be confusion, neurological manifestation, obtundation can set in. And below 30, below around 40, the seizures will set in, coma, and at around 20, complete brain damage. So our patient who went to the ward came at a near arrest, came with a sugar level of 32. Luckily, she didn't have seizure, but she became very obtunded, almost a point we had to necessitating possible intubation, but she slowly recovered. She had prolonged slurring of speech, so on and so forth. So basically, they can slip into coma, and we have had hypoglycemic patients coming with brain dead also. So it is as sinister as that. So I'm sure many of the listeners would have seen patients who had protracted hypoglycemia, cardiac arrest, becoming brain dead. All these are narratives we have heard. So it's not a very simple thing, and we have to pay a lot of attention to put in measures, especially in ICU, to prevent further progression of hypoglycemia. And this is terribly important. This slide, pay attention. This is the quintessence as to why elderly are vulnerable to go into hypoglycemia. If you look at the young, just focus on your left side, young patients, look at this, there is a greater time for corrective. So because the thresholds for clinically manifesting hypoglycemia occurs at a much lower level, because the awareness kicks in at around 63 or more than 60. And there is a lot of time before cognitive dysfunction sets in. And if you see this bar after 65, that's why I want to get this point across to elderly patients, your awareness thresholds tend to go down. So which means they fail to become aware of hypoglycemia and the cognitive so there is very less margin between the awareness and the cognitive dysfunction or neurological dysfunction that tends to happen. So there is very less time for them to realize that they've gone hypoglycemic, and that is when the sort of a down spiral tends to happen, because cognitive dysfunction happens much early on and they don't have much margin before the hypoglycemia set in. The thresholds tend to come down very severely. Very beautiful depiction. Your awareness happens at a lower down, and even your cognitive dysfunction happens at a little higher level than compared to the younger individuals. And what about cardiovascular response? So, and it is shown that hypoglycemia leads to activation of your inflammatory cascade. So this septic patient already would have inflammatory cascade which is activated. So even hypoglycemia happens, it actually worsens the outcomes in this setting, because the inflammatory cascade can worsen. CRPs go up, IL-6, all the inflammatory mediators go up, because there is sort of counter-regulatory mechanism which is activated with epinephrine release, cortisol release. Your cardiac workload happens, they go tachycardic. So obviously your cardiac contractility increases, your cardiac output increases, and they are at a risk for myocardial ischemia. And it is shown they have endothelial dysfunction and vascular response to vascular dilatation, or the vascular response get muted. And even it is shown hypoglycemia can lead to activation of fibrinolysis, and coagulation cascade can get activated, and coagulation abnormalities. So which basically the whole inflammatory cascade can get activated in severe hypoglycemia is what has been referenced. And let's look specifically why we pay so much attention to hypoglycemia and its effect on the heart. At a blood sugar level of 52 to 58, it is shown that QT can get prolonged and they'll start having ventricular ectopics. So this is something that happens. And once your blood sugar level goes to less than 40, they can go into brady and cardiac arrest. So this is what happens. So which means cardiovascular deleterious effects happens at various levels of blood sugar levels, and there can be variable morphology of the P wave. And moderate hypoglycemia has shown to, again, the repetition, it increases your inflammatory cascades, it can lead to acute coronary syndromes. And in type 2 diabetes with hypoglycemia, there can be reduced heart rate variability. And this is another depiction of in-hospital mortality by glycemic status. So there is one point I want intensivists to make a note. I'll just tell upfront. So in patients who are diabetics, who are on insulin, the outcomes are better as opposed to patients, diabetic patients who are not on insulin. Patients who are not on insulin, outcomes are bad. So see, as you see, these are non-diabetics having hypoglycemia, mortality is higher as opposed to diabetics who are on insulin. So non-diabetics, if they become hypoglycemic, the outcomes are bad. So now we'll go to the studies. I think these studies are extremely important for all our intensive care friends. These are all the landmark study and why we don't adopt TGC. Why in intensive care we don't like the philosophy of tight glycemic control. These are the landmark studies. So the one study, so just pay attention, it's a YSEP study done in 537 patients where they compared 80 to 110 milligram per deciliter versus less than 200 milligram per deciliter. And hypoglycemia here was defined as less than 40 milligram. So 17% of the patients who were in 80 to 110 developed hypoglycemia versus 4.1% in less than 200. And mortality impact study was terminated because of deleterious effects of more hypoglycemic events happening in the TGC, tight glucose control. So this is a group control study, 1,101 patients. Again, they compared 80 to 101, which we call it as TGC, and compared with 140 to 180. And as you see, sorry, it is 8.7%. 8.7% of 80 to 110 had hypoglycemia versus 2.7%. Even their study was terminated. And nice sugar, this is the largest study. I'm sure you all would have heard of this nice sugar, which came from Australasia. It's a multicentric trial. 6,104 patients compared 80 to 110 versus less than 180, which we are following. Today, we try to maintain sugars less than 180 and we don't want it to go at 80 to 110. Why? Because the hypoglycemia was 6.8% versus 0.5%, and nice sugar study showed there was 2.6% increase in the mortality at day 90 in patients who are maintained at a tight glucose and who had a more hypoglycemic events. In that hypoglycemic, there was 2.6% increase in mortality at day 90. And then there is Digami study, which is an older study, 1,253 patients, where they compared three arms, IV insulin for 24 hours with basal bolus versus standard. And they found that the hypoglycemia events was 12.7% in intensive care where IV insulin was used, where intensive TGC, tight glucose control, versus 9.5% versus 1%. And here they did not find a statistically significant mortality. So these are the landmark studies where clearly it is shown. If you try to maintain TGC, the risk of hypoglycemia is high and it may have bearing on mortality. So that is the message. And this is another important study where they showed hypoglycemia increases mortality by twofold in patients with acute. So if someone has already ACS or ischemic heart disease, hypoglycemia can be even worse. So this study came from this particular study, which came from JAMA, which was a 5 years retrospective study done in 40 hospitals. So this is very interesting. This is the message I gave you loud and clear earlier. If someone is not on insulin and they develop see, these are diabetics who are on, say, OHS, who develop hypoglycemia. And if you see here, the mortality was 18.4% as opposed to 9.2% in patients who did not develop hypoglycemia. That was statistically significant. And this is interesting. So this is a patients who had hypoglycemia but were on insulin with hypoglycemia versus no hypoglycemia, there was no mortality difference. So which means to say diabetics, insulin has some protective effect on the heart. That's what it means. So someone who is on insulin, like our patient was on insulin, possibly that's why she survived. She went home. Had she not been in insulin, maybe she was on OHS with a IHD, with a coronary artery disease on the background, maybe her outcome would have been even bad. That's what these studies showed, that insulin has some protective effect. Diabetics who are not on insulin, the mortality is much higher if they develop hypoglycemia. That's what this study showed, which came in JAMA. And this is the forest plot, which shows you can see high mortality in all subgroups of patients in patients who are not on insulin. And this is the forest plot of patients who are on insulin. As you see, statistically, it did not attain statistical significance. And let's look into hypoglycemia and CKD. This patient had AKI bar CKD, AKI actually, not CKD. So as you see, there is a proportional increase in the risk of hypoglycemia in patients who are on CKD, 8.4. So nice sort of a bar diagram. CKD with diabetes, your risk of hypoglycemia is 8.43%. No CKD with diabetes, 4%. CKD and no diabetes, 1.6. No CKD, no diabetes, hypoglycemia is less. So basically, CKD with diabetes are at a higher risk of developing hypoglycemia of varying degree. And what is the potential mechanisms of hypoglycemia induced mortality, cardiovascular mortality? It is shown that patients with hypoglycemia are at an increased risk of developing thromboembolism, maybe arterial, more of venous thromboembolism. There is inflammatory cascade that goes up. They are at a risk of MI, and they are at a risk of arrhythmias and tachycardia because of the adrenergic response that we saw. So these are some of the mechanisms that are purported as a risk for cardiovascular mortality. So I'll talk about management in a snippet video I'll do later. So the conclusions for all my intensive care friends is, please understand the prevalence of hypoglycemia sits at around 29% in diabetic patients. In ICU, please remember the figure, 5 to 6.3% is the sort of a prevalence rate of hypoglycemia in ICU. And this increases when they have CKD. This becomes higher. And counter-regulatory hormones or counter-regulatory mechanisms get mitigated or dwindled in elderly patients. As we get elderly, our counter-regulatory mechanisms get very muted. So there's no adrenaline, there's no norepinephrine, there's no cortisol release, there's no glucagon release, and they are at a risk of hypoglycemia. And these are the patients who are vulnerable, and there is an increased mortality. And this increase in mortality is shown more in sort of a non-diabetic patients, and who are diabetic patients who are not on insulin, who are not on insulin, who are not on insulin, this happens. So that is important. That's an important message. And hypoglycemia increases the risk of cardiovascular events. So this is something we all need to understand. That is why it's a malpractice. If someone has hypoglycemia, send them to ward in an elderly with an AKI, where counter-regulatory mechanisms are impaired, where hypoglycemia awareness may not be there, especially in a post-operative setting where they're recovering from anesthesia. Most studies have shown tight glucose control increases the risk of hypoglycemia. So that's about it, folks. So thank you very much. Request you all to submit your valuable work to Journal of Acute Care. So you can visit my website to read to this lecture. So this is a nice proverb. Some people hate you because you had less and still did more. Thank you. Thank you, Window.